Hey guys, welcome to Medifaction. Today, let's learn about multiple myeloma. So let us begin by observing a histological slide, which is a peripheral smear of a person with multiple myeloma, and we can easily identify the Rowley formation of the RBCs, otherwise known as clubbing of RBCs, which is a feature of multiple myeloma. Likewise, this right here is a bone marrow aspiration smear showing the plasma cells, and by observing the plasma cell you can easily appreciate that the nucleus is eccentrically placed, which is another feature. So this is a closed image of a bone marrow assay, this one also. Likewise, here we can observe a skull bone showing lytic lesions. So these all are connected with multiple myeloma's clinical features. Now let's go in deep. First of all, plasma cell neoplasms. These B cell proliferations contain neoplastic plasma cells that virtually always secrete a monoclonal immunoglobulin or immunoglobulin fragment, which serve as tumor markers and often have pathologic consequences. Collectively, the plasma cell neoplasms, often referred to as dyscrasias, account for about 15% of the deaths caused by lymphoid neoplasms. M protein. It is a monoclonal immunoglobulin identified in the blood, is referred to as an M component in reference to myeloma. Plasma cell neoplasms. Classification. These are based on the monoclonal gammopathy of undetermined significance, also known as MGUS. So here are the classifications, which are plasma cell myeloma, which composes of certain variants such as asymptomatic myeloma, non-secretory myeloma, plasma cell leukemia. Another classification is plasmacytoma, which possess variants such as solitary plasmacytoma of bone and extraosseous plasmacytoma. And also we have immunoglobulin deposition disease, which comprises primary amyloidosis and systemic light and heavy chain deposition diseases. Diagnostic criteria. The serum M protein should be less than 3 gram per deciliter in case of multiple myeloma. And also the BM clonal plasma cells is less than 10% and low level of plasma cell infiltration in trephine biopsy. And there won't be any lytic bond lesion and no myeloma related organ or tissue damage, which is based on CRAB, which is a mnemonic which we will be learning in the future, and also no evidence of other B cell lymphoproliferative disorders. Plasma cell myeloma. So plasma cell myeloma is a bone marrow based multifocal plasma cell neoplasm associated with M protein in serum or urine. These are also known with other names such as multiple myeloma and also medullary plasmacytoma. These constitutes about 1% of all malignant tumors, 10 to 15% of hematopoietic neoplasms, 20% of deaths from hematological malignancies, and male is to female ratio is 1.4:1 and 90% in above 50 years of age and 3.4 or 3.7 fold risk in first degree relative. Now let's see the etiology. So in the case, firstly, there will be a chronic antigenic stimulation due to infections, toxins or radiation which leads to multiple benign clones which come across a stage of mutagenic event which results in the malignant transformation. Sites of involvement. Bone marrow, which are the areas of most active hematopoiesis such as vertebrae, ribs, skull, pelvis, femur, clavicle, and also scapula. Lytic bone lesions with focal tumoral masses of plasma cells. Now let's see the diagnostic criteria for plasma cell myeloma. In the case of symptomatic plasma cell myeloma, the diagnostic criteria are M protein in serum or urine, bone marrow clonal plasma cells or plasmacytoma. Also, CRAB, which I have mentioned earlier, is nothing but a mnemonic to remember hypercalcemia for C, renal insufficiency for R, anemia for A, and bone lesions for B. CRAB. To diagnose asymptomatic or smoldering myeloma, the M protein in serum at myeloma levels will be greater than 30 grams per liter or 10% or more clonal plasma cells in the bone marrow and no end organ damage or bone lesions such as CRAB condition or myeloma related symptoms. Bone pain, lytic lesions, fractures, generalized osteoporosis, and vertebral collapse. Recurrent infections, which is due to depressed normal immunoglobulin due to displacement by the neoplastic clone. Anemia, which occurs due to marrow replacement and renal damage. In 70% of cases, lytic lesions, osteoporosis, fractures, vertebral collapse due to extensive skeletal destruction by neoplastic plasma cells. Peripheral blood in plasma cell neoplasms. As I told earlier, there will be Rowley formation, there will be leukopenia or thrombocytopenia. Also, 15% of cases shows peripheral blood plasma cells in small numbers and also marked plasmacytosis in plasma cell leukemia. Now let's see the macroscopy. In multiple myeloma, in macroscopy, bone defects on gross examination are filled with a soft, gelatinous, fish flesh-like hemorrhagic tissue. Right here you can observe. Mature plasma cells, which are oval with a round, eccentric nucleus and spoke wheel or clock face chromatin without nucleoli with abundant basophilic cytoplasm and a perinuclear half. Inclusions. First is Mott cells or modular cells, which are multiple pale bluish-white grape-like accumulation. We can also identify Russell bodies, which are intracytoplasmic and intranuclear cherry red refractile round bodies. Flame cells, which is vermilion staining glycogen-rich immunoglobulin A, and also Dutcher bodies, which are large and pale staining intranuclear inclusions. Bone marrow biopsy. There will be interstitial clusters or focal nodules or diffuse sheets. If greater than 30% of the bone marrow volume is comprised of plasma cells or a tumoral mass of plasma cells is seen, displacing normal marrow elements, a diagnosis of plasma cell myeloma is likely. Prominent osteoclastic activity may be observed, results in lytic lesions seen on X-rays, which we have seen on the previous slides. Approximately 9% of cases of myeloma show reticulin fibrosis, like this, and correlates with extensive diffuse marrow involvement. Renal damage. Bence-Jones protein. These are light chains of immunoglobulin forming intraluminal eosinophilic material in renal tubules. Renal damage results from tubular absorption of Bence-Jones protein. Immunophenotype. The plasma cells express CD138, which is an adhesion molecule also known as syndican-1. CD56 aberrantly or abnormally expressed in 67 to 79% of cases. Now let's move on to treatment. MGUS or asymptomatic plasma cell myeloma does not need any treatment but follow-up. In case of symptomatic plasma cell myeloma, they will be giving alkylating agent plus alpha interferon. And if there is a case where alkylating agent resistant condition occurs, VAB regimen is given, which has vincristine, doxorubicin, and dexamethasone. And another treatment option is bone marrow transplantation, and also monitoring for relapse or progression with serum beta-2 microglobulin levels and urine monoclonal proteins. Prognostic and predictive factors. Myeloma, cell burden, renal function impairment, raised serum beta-2 microglobin, low serum albumin, raised serum LDH, raised CRP, plasma blastic morphology, and also genetics. Hope you have understood the video. Like, subscribe, and also press the bell button for more videos. Thank you. Thanks for watching.